welcome to this afternoon's panel discussion for Clear Week and entitled Recovery and Transformation, Can the NHS Achieve Both and in Equal Measure? It's great to see so many friendly faces on the call, and I'd like to welcome everyone who's joined for the first time for Clear Week 2023. This is a panel session where what we're doing is showcasing the work of frontline staff who've been delivering innovation projects to change clinical service across the NHS. My sincere apologies for my voice today. I have literally got a frog stuck in my throat, which is a significant irony for an anaesthetist, because that's one of the things that should not happen. So apologies for the husky tone. But our panel discussion today is one of our key sessions, and the topic is recovery and transformation. Can the NHS achieve both in equal measure? I'm delighted to be joined today by Janet Crofts, who's the Managing Director of the Greater Health Manchester Primary Care Provider Board, Marc Lyall, who's the Associate Head of Workforce Transformation for Health Education in England nationally, Nav Chana, who's the Non-Executive Director at Lewisham and Greenwich and Kingston Hospital, as well as the NAPC Clinical Director and a GP in South West London, and Maria Portugal, who's a A&E sister, as well as being a Clear Project Delivery Lead. And a special mention to Maria, who's joined us today, as she's got a very little one at home, so it's nice to see her after the last couple of months. So please, can everyone note the webinar is going to be recorded, so we can share it for colleagues who aren't able to join this at this time. And if there's any colleagues who are keen to follow us on Twitter, some information is going to be provided in the chat. So our topic of discussion today. The NHS continues to face extremely challenging times. It's been a very, very difficult winter. I mean, not just a difficult winter, it's been a very, very difficult couple of years. And it's been quite inspiring to see the resilience of colleagues who've demonstrated a huge amount of resilience and perseverance to deliver the best possible care they can in what is incredibly challenging circumstances. Whilst there has been some progress made to tackle the backlog, there are still really significant challenges across every part of health and care. That's acute community primary care, as well as social care as well. And there's a lot that needs to be done to try and get ourselves back to the position that we were in pre-COVID, to specifically around trying to reduce any waiting times, improve access to primary care, and also reduce the delays that we have in elective care. As one of our speakers said earlier today, one of the other things that we need to do in the NHS is bring joy back to work, so that our colleagues experience the fun and the satisfaction that you can and should get from working in healthcare, because this is going to be absolutely critical to delivering successful transformation, reducing health inequalities, and improving retention within across the NHS and the care setting. So, without further ado, what I would like to do is to hand over to my colleague Janet to start the conversation today. And Janet, thank you very much for your time. And I was just wondering if you could give us some thoughts on whether you think recovery and transformation can actually be achieved in equal measure.
Thanks, John, and hello everybody. It's great to be here, and really thank you, John, for asking me to join you today. Gosh, that's the $1,000,000 question, isn't it? And it's who thought that we would be where we are now 5 years ago? I mean, probably a similar time that John and I met. First of all, doing some transformation work in Greater Manchester. Who thought that we would be here, having transformed incredibly through that period of COVID and the pandemic, but actually also slowing our transformation programs down because we simply had to put some things on the back burner. So I'm going to make no apologies for me talking about primary care from my point of view, because that's my current job, but I'm an NHS manager who's worked in all areas of the health system, and I can probably jump into other areas if we need to. But if I think what my day job is and where I've worked through the period of the pandemic in primary care, what we've seen is a new lane on the motorway. There has been a new lane on our motorway, and that has been virtual appointments and virtual access, using our websites, using digital in a way that we've never used it before. Well, we probably should have been using it before, and we probably were behind the curve when it comes to that transformation. But actually, overnight, COVID enabled that transformation, and suddenly we were using virtual technology to go about our everyday business. The outcome of that has been that there is simply this extra lane on the motorway now, and we've not got a handle on the demand we have in primary care. We have an open door, and services as they are proudly across the NHS are free at the point of delivery. So we opened another door and patients flowed through. And now we've found ourselves at the other side of the pandemic almost, with that other lane open, and trying to make sense of what was a necessary way of working 3 years ago. And is that good and is that bad? Well, I think it is good because we were slow and paced at our pace of transformation when it had come to digital, and we clung on to those old ways of working, old ways of accessing the service. Suddenly, within a couple of days, we couldn't do that anymore, and we opened up lots and lots of complexity into the system. And actually, our role now, 3 years on, is to make some sense of that and start to think about actually how do we order that into what has actually been good. So the ultimate PDSA cycle, for those of you who are into quality improvement, the ultimate PDSA cycle that we'd have been scared to do had we not had the pandemic, we flew into it and we did that testing, and we did that testing well, and we did it at scale. So we're learning now and trying to put into place all those stepping stones that means that we keep what is good, but actually we reflect and don't keep what wasn't good. And I think that is massive and huge, and it hopefully will never happen again for us in the system. So in answer to the question, can we transform and recover at the same time? Yes, because we've got to. Absolutely, because we've got to. But actually, we can learn from what we've transformed into. Our system is very different than it was before. Can we learn from that and take the best from it? We're left, I mean, in Greater Manchester, we've got massive challenges. We've got massive challenges around our elective waiting times. We've got huge challenges in primary care around access and around providing our citizens for what they need and meet their expectations. But we've also come on great strides. So while all of this has been happening, we have been improving and moving forward. We now in primary care have a large number of additional roles in primary care. Our workforce has expanded hugely during this period, the period of the pandemic, and actually gives us a stepping stone and opportunity now to use those people differently, to use them to best effect within our system. And all this has happened in a bit of chaos over the last few years, but now we're making an order of it. And that brings us into John's work in Clear, and the work that I've experienced around anticipatory care has really helped us to order our opportunity into something that's really meaningful going forward. Before the pandemic, we didn't have those additional roles in primary care. That was always policy, but we didn't have them. And that change has happened over this period of time. And now we're putting that to good use. So putting that good use, so we mustn't waste that amazing opportunity that we've got. We absolutely mustn't waste it, and we must use that to best effect and take our service from where we were 3 years ago to where we have been during a pandemic period, where we've just been holding it together and focusing on vaccination programs, etc., then to take us to the next stage where we can really get down to personalising care, identifying people who are at risk and risk stratify and make sure we target those people who really need it and change the dial. So you said before, you intimated happy staff, happy patients, and I love that. I love the idea of that. But actually, how can we, create that difference, that move the dial with the public and our citizens, so that they're reporting that they're very proud of our NHS. They don't always, do they? And it's such a shame. How can we change that dial, and so our citizens report that they know that their NHS is working hard for them, and they know that we have their best interests? And that, I think, is a really big challenge for us because of the difficulties and the restrictions we've had, and because of the huge challenges we've got. So wouldn't it be great if we can take small steps to changing that perception and really meeting the expectations of those who use our services, which is all of us, as well as all of those who are not in the health system. I'll not say any more, but I'll be really delighted to hear questions and hear other people's thoughts.
That's very kind, Janet. Thank you very much. We'll have a section at the end for questions and thoughts, because I think that your views, you mentioned some really interesting issues there, especially around the rapid transformation, and then the need to come to a new place of order in a new world. I mean, in effect, it's two sets of rapid transformations. You've gone from 2019 to COVID to the new normal, in inverted commas, and so that's a lot of change for many people to take on board, and to keep people happy and proud of the NHS throughout all of that, especially given the challenges that we're facing just generally with inflation, cost pressure, etc., is really, really difficult. But I completely agree with you. It's an aspiration that we need to have central to what we do. So that's really, really helpful. And I think just following on from that, Marc, from your perspective, do you think that we can achieve recovery and transformation in equal measure?
I'm just going to blindly ignore that question and pick up a point that Janet made, which, because I'm a great observer of the way traffic moves on motorways. It always interests me how things go quickly, slowly, bottleneck and what have you. And that extra lane in the motorway kind of analogy, metaphor, Janet, is quite incredibly powerful, right? Because we observe lots of motorways, especially, well, I see lots of pictures from cyclists about motorways in the US, and these big, rapidly expanding, increase the lanes and more traffic comes in. And there's something about, the opportunities and the learnings that came out from that extra lane that came in during COVID, and the way in which people responded at speed and decisions were made very quickly, which needed to happen, but also was also quite refreshing that it could happen. But then there's also something that then picks up that thing, which is now you've got an extra lane and you've got the doors opening with regards to quicker adoption of some digital solutions. How do you kind of make sure that you're not creating a bottleneck inadvertently as a result of that? That's as far as my thinking on that analogy goes, so I'll drop it. But there's definitely something there about the opportunities that we've realised over the last few years, and the kind of impetus that's been gathered. But I think, going back to your question, for me, there's something here which goes, recovery probably wouldn't happen without transformation. But I do think transformation's a bit of a loaded term as well, because it can sometimes set an unrealistic set of expectations in people's minds that what's needed to happen is unachievable, and actually it's entirely achievable. So we need to recognize the successes and the changes that we encounter and achieve on a kind of week by week, month by month basis as well, and not have this kind of golden glowing thing in the distance that we think once we've reached that, success has been kind of, we've achieved success. There's lots and lots of wins that you encounter and you create as you move towards the kind of golden glow in distance. I think from a national perspective, sorry, I was just some thoughts that came to me as Janet was talking. I think from a national perspective, there's definitely something here about building capacity and capability for people working within trust, within systems, to do workforce transformation, and how that manifests itself. There's, relatively new ICS, ICBs, lots of change going on continually in the sector as well. So what can we do with and through CLEAR, with and through other kind of workforce redesign methodologies to give people assurance, give people confidence, and give people processes which they can start to address their workforce challenges that they have. As well as there's the kind of age-old thing about spread and adoption and sharing best practice, which can feel incredibly difficult, certainly from a national perspective. Not necessarily difficult to do, but difficult to get bite on, and marrying that, there's lots of great work that's going on across the country, across regions, across ICSs, and sharing it in a way that you kind of inspire, motivate, and give people adequate information and learning to help them move forwards themselves. And not everyone's going to be ready to, not everyone is in a position to be trailblazers or leading the way. There are going to be people who are going to be following and picking up the really important learning that happens. I think those are some of my thoughts around this. I think there's a lot that needs and could be done, but I think there's some really fantastic opportunities, and there's loads of great work out there that we're seeing, through the work that you've done, through the work that colleagues within HE and NHS are doing. I was involved in several programs of work nationally around theatres, outpatients, eye care workforce. So there's any number of opportunities and great work that's been done. I'll pause there, John.
Well, thank you very much, and I think just to echo some of your points about it was very refreshing how fast things changed in COVID. It's like something I've never seen in the NHS before, and I doubt many colleagues that have seen that kind of pace of change. And it's as you say, a little bit. It's a shame that some of that pace hasn't been able to necessarily be upheld, but that is for obviously for good reason. And I agree with you that recovery won't happen without transformation. There's always going to need to be change within the NHS, and if we don't build capacity and capability, we're constantly and investing in it constantly, we're not going to be able to realise anything like the benefits that we need to. So wholeheartedly agree with you there. But I imagine that Nav will have a number of valid points to add and expand on. So Nav, over to you.
Thank you, John, and thank you everybody for in anticipation of listening to anything I've got to say. I kind of just start with the question, John. Recovery and transformation. I think. Without resorting to semantics and definitions, they're often kind of used interchangeably, aren't they? And sort of, and actually, they actually mean very different things, don't they? And so, in just being very crude about it, recovery to me means getting back to where we were. And that means, was that before pandemic? Does it mean, what period of time are we reflecting back to? And obviously. Transformation is evolving things to a better place, and depending on which lens we use, is that from a patient perspective or a workforce perspective or a system perspective or whatever. So I think we've got to be careful that we understand what we mean by these things. Recovery for me has got sort of tarnished a little bit by the political narrative around this, because it sounds to me a bit like people thinking, well, actually no one's doing anything in the NHS because why are there waiting lists, and why are there patients clamoring to see their GP, and you kind of miss the point that actually everyone's working as hard, if not harder, than they've ever worked before. The productivity is greater, the challenges are greater, and I feel that the term recovery is associated, in my view, with slightly bad press. I think probably better to think about transformation, which is, let's forget about recovery. Of course we need to recover, but we need to get better than we've ever been before. and what are the things that we can start to do to create the environment for transformation. And I hope that Janet and Marc will perhaps agree with me that sometimes transformation doesn't just happen out of the blue in a strategic paper that lands from top down and people are told to kind of transform. Transformation happens. I'm sure, Janet, you'll have experienced this when you create the environment and the environmental conditions through which transformational things can start to happen, and little shoots of transformation happen, and you connect them and you grow them and you learn from them and you share them and you spread them and so on and so on. And I stress this, John, because after 31 years of being a GP, having worked through 19 primary care reforms over that period, each reform lasting on average 2 to 3 years, I kind of reflect back on why we have not learned from the things from before. So, if I may, on a slightly more positive note, start to say a few things that I think I've learned in recent weeks and months, talking to a variety of clinicians, and I'm being very explicit about this being a clinically led conversation, because it's essentially the clinicians that commit the resources that we spend in the NHS. So having clinicians engaged properly in things is a really important construct. So that was the first transformational point. Let's really get our clinical teams engaged properly in what it is we're transforming and how we could transform these things from their perspectives and their experience. And of course, what we tend to do as a shortcut to that sometimes, I'm sure that's not true for Janet and Marc, is that we tend to pick out the positional leaders, and we somehow think that because we've discussed it with the positional leaders, we've now engaged the whole clinical community. And of course, we recognize that that's probably somewhat flawed thinking. So first transformational point, let's make sure change is properly clinically led. And John, to talk music to your and Clear's ears, that it's data driven and it's the data that drives us in the right direction, so that we're prioritizing on the right things that we need to transform around, rather than the things that people think we need to transform around. So that would be the first point. The second thing, I think Janet has demonstrated already this in Manchester, Greater Manchester, that we need to create a common sense of purpose. And that's a common sense of purpose across all clinical teams, whether they're in primary care or secondary care or whichever sector they operate in, particularly because without that, we're still in this culture of competition versus collaboration, which is where we're trying to really get to. Looking at the power of technology, which we've learned from the COVID experience, and how we can really develop that greater use of technology construct, not just in terms of transformation, but things like climate change, things that sort of really are going to affect us over the next 4 to 5 years, the pandemic to come, the challenge of climate change, and start to think about how we kind of incorporate those technologies, some of which are going to be patient facing, some of which are going to be workforce facing, some of which are going to be around back office automation and replacing the things that we could arguably do more effectively. And then the final point, John, is really about creating the expectation that as providers of services, whether you're primary care providers or secondary care providers or community providers, mental health providers, that we are actually really genuinely collaborating and not pretending to collaborate. And I think the reason I say that is because, of course, organizations can set out their kind of mission statements and commitments, but it's actually the clinicians that we really need to bring together around common purpose and common objectives. So we've got, tertiary end neurosurgeons working alongside our mental health colleagues and our GP colleagues. So we just create a better sense of a clinical community that's focused on the right sorts of things that will improve both the demands that we're facing, but also that sense of fulfillment of being at work and not feeling constantly that you're chasing your tail all the time. So I'll stop there, John. I'm sure I've probably said a few things that might create a few raised eyebrows, but let's see where that takes us.
Nav, you never say anything that raises an eyebrow ever, so this will be no. I'm first. I genuinely the points you've made about genuine collaboration and the use of technology alongside wider engagement of all clinical colleagues across all professions, I think is fundamental. When I first started doing this work, I was very medically focused, because that's the way I've been trained. And one of the things I've seen is that it doesn't matter what your background is. We are one holistic team, and if we work as one holistic team across all of the different professions, we will give the best for our patients. But that collaboration has to be genuine. It has to come from the heart. And I think that we're fortunate that we're seeing a lot more of that now than I think we did even a decade ago. So thanks, Nav. It's really helpful comments, and appreciate it. Now, Maria, I'd be obviously from your perspective, very keen to hear your views, not just about recovery and transformation, but anything that that's piqued your interest from what colleagues have said over the last 15-20 minutes.
Thank you, John. Thank you, everyone, for having me in the panel. It's very exciting to see so many friendly faces after I've been off for a few months. So for the people that don't know me, thank you for the presentation, John. I am an A&E sister, and I was in 2019 when I first joined Clear, and I was lucky enough to be part of one of the first UEC projects, Urgent in Emergency Care. So I do agree with Nav to say that I'd rather speak just of transformation rather than recovery, because I'm not sure that where we want to recover to, and we were already talking about transformation before COVID, and that's the way forward. But my thoughts today, and in every role that I've taken, both in the NHS and Clear, have been always about empowering people, and that's why I'm so passionate about Clear. We know how tired and how demoralized a lot of our colleagues are in the teams across the countries in the NHS, how hard everyone works, and how difficult it has been, especially since COVID, and why people haven't been able to keep that productivity that we were talking about. But also how a lot of teams have been losing a lot of their precious and very highly skilled colleagues in the last 2 years, let's say. So it really comes as no surprise to me that when we start having conversations with the leadership teams at the trusts, that the first really pushback that we have is how can those leaders release senior and very high skilled people for these transformation projects, and in particular for 6-month projects like the ones that we drive here at Clear, since their teams are already so thin. But then, and I think that's the challenge today when we're talking about transformation, and the challenge that I always give back is how you're retaining that senior staff and that high skilled staff, and what makes them stay. And I think that's what's really important for these teams. But within Clear, thankfully, through these years of projects, we have proven that the Clear projects work, have a meaningful impact. And by this, I mean the outputs are good and they are generally accepted by the teams, and they get implemented sometimes still during the duration of the project, because the staff and the clinicians, they feel that they were part of the change. They feel that this change was data-driven, as Nav alluded to, and they understood where the change was coming from. And I think that's really important. That's why we have impact, and there is real transformation with our Clear project and with our teams. The clinicians felt heard when they were part of clinical engagement. So we keep clinicians at the center of the project, and they felt empowered because they were learning new skills. They were learning about data, having the space and the opportunity to listen, but also having honest conversations with their leaders. And I think that's something that unfortunately it's not very common in the NHS. There is pretty much the clinicians and there is the management teams, and the clinicians feel that the management teams are not achievable, they are not there, and they cannot have conversations with them. And I really feel that I've been working, especially in my last role as delivery lead within Clear, is this empowerment that makes them stay. It is empowerment of clinicians that makes them work better and be better at what they do. We have had a number of colleagues being promoted within their teams to more senior roles while they were doing the clear projects, and in consequence of the outputs that they demonstrated to the boards and to their colleagues and to their leaders. And that's really encouraging as well for us, and particularly for me, to see how we start working with teams and with clinicians, with sorry to bring it to me, but with nurses and with doctors and with physiotherapists and with social workers that say, I don't know anything about data. I can talk to those people, and within 3 months, yes, I'll go and speak with that director. That's no problem. Yes, I understand data, and I can prove this, and I can build a new model of care, and I can build more workforce, and I can calculate the impacts of my measures. So this is really my piece of thought for today. In my opinion, if we want a meaningful change and sustainable transformation, the people have to be at the center of our concerns, and not what we are aiming at. It doesn't matter what form of transformation it comes at. It may be a new model of care. We were talking of new ways of working to be more efficient, new roles. It doesn't matter, but it's not sustainable as long as it's not data-based and people working for it don't understand it. And that's me today. Thank you.
Maria, thank you. And I alluded to this at the start, but I would, if I was as articulate when I had a 3-month-old at home, I would be incredibly impressed with myself. So thank you very much. It was a lovely point to make. I guess just reflecting on, I mean, you made some really interesting points there, but the key thing that resonated for me was around how important it was to have board-to-ward engagement when it came to delivering complex change, how important it was to have staff fully engaged and upskilled as part of the process, and how important it was to empower people to do it for themselves. And with those key things, then, you know, I think we do have a shot of making things, making change stick in a way that does improve care. I mean, I've been jotting down some notes as Janet, Marc, Nav, and Maria have been talking, and some of the interesting points that have been made, and it's quite difficult, actually. I'll just be very candid. It's quite difficult. There's quite a broad range of points that has been made, and it's quite difficult to draw them all down into key themes. I don't envy people who chair for a living. It can't be that straightforward. But the points that I guess I've heard is that transformation needs to be our focus, and if we focus on transformation and doing it well, we can realize the benefits that, or the doors that have been opened, and the motorways lanes that have been created, as a result of well, the change to COVID, and then the change from a COVID life to the new normal, and I guess that will involve the use of technology, the capability building in staff, to allude to points that Nav, Janet, and Maria have all made. And I suppose the final point about it is that the biggest challenge is creating the time and space for people to do it when we have the sort of ongoing and enduring service pressures. I was going to sum up a little bit and say to Marc and Maria, Nav, and Janet, what do you think? But Marc, you've sort of beat me to the point.
That's all right. No,
put
my hand up. There's a point here around culture, isn't there? I think as well, which is very ephemeral and all wrapped up with, you know, cultures in use versus those that are espoused by an organisation. And dare I say it, we work in a number of organisations under a banner of the NHS that has a very strong espoused set of cultures, but some very different cultures in use. And the culture that leaders in an organisation or a system have are as key as any of those other factors, one might argue, in terms of empowering, in terms of giving people permission to transform and do things differently. And when Nav was speaking, the point that you made now kind of triggered off in my mind, which was, yeah, I think I'm going to put words in your mouth, but they're going to be wrong, so correct me. But there was something about the tension that comes down from nationally driven initiatives, and there's a couple of thoughts that sprung to mind there, which is there are a lot of really great people and great teams and great services that are disruptors, disruptive innovators that are doing things without permission because they can't get permission, or they don't ask for it because they know it'll get kiboshed. And that's a really interesting kind of group, which I imagine would scare a particular management type that wanted to control. The other thing is viewing national initiatives as opportunities to springboard off and maximize to what's needed on the ground, so not to see them as a threat. And sometimes they can seem very, you must do this, you must do that, and that's how they can seem, and probably are sometimes. But for me, there's always an opportunity there about looking about what you're trying to achieve and finding of things that can complement that, which potentially have resource capacity associated with it. Not suggesting that's easy in this current climate or at any time, but those were just some thoughts I wrote down, John. I'm not sure if they're helpful.
No, always helpful, Mark. And I'm keen to ask, given the themes we've just heard, I'd be keen to get some more thoughts from Janet, yourself, Maria and Nav, for about 5 or 10 minutes before opening up to the floor for any further questions. But Nav, it looks like you're about to say something. Janet, yeah, please.
Janet first, then John.
Yes.
Oh gosh, I politely put my hand up there. I didn't know what to do. Whether and I'm sure, I'm really feeling that we're on a similar wavelength here, and I love the fact of that disruptive innovation. I think you've got to do it. You've got to do it. I put John in that camp, actually, that disruptive innovation, that you've got to do it, because you'd always do what you've always done. And I think we smother ourselves for very good reason very often. And I'm a fan of good governance, but actually we smother ourselves in it, and we can't get to the wood because of the trees. We really can't. We struggle to get things through and to worry about things. I'm a great believer in testing and seeing what works. And if it does work, let's run with it and let's spread that good practice. If I'm honest, I think in the NHS we're very bad at spreading good practice. We're very bad at celebrating and saying to our neighbour, you've done a great job, let me do it, instead of wanting to invent it ourselves in our own backyard. And we've just got to get over ourselves there, because we could put our hands on our hearts and say we're a public facing organisation, the public pay for this. We should behave in that way, where we celebrate each other's success. We say, don't we, a good leader helps others step up, and I do believe that's what we should be doing. And I sort of really feel strongly about that, because we see some fabulous practice that never ever surfaces itself and gets buried, and we don't grasp it and run with it. And I run the Digital First programme for Greater Manchester. I'm SRO for it, and I'm very proud to be so. And I'm at that point of spread. I'm at the point of wanting to spread good practice and spread what people are doing. First, people are really reluctant to give me their good practice. I want to celebrate it, and they're saying, "Oh, no, I don't want to share it." And they are sharing it now, but they've done some fantastic stuff. And then I've got to figure out a way, and it's my biggest challenge, is to figure out that way of taking that good practice and supporting others to pick it up easily without concern. And that, I know is my biggest challenge in that programme. And it shouldn't be, should it? It just shouldn't be. So anyway, I'll stop talking now, but I feel very passionately about that.
Just to add on that, Janet, it's really interesting how different the point you made about people are reluctant to share. There is a culture, there is a set of behaviours that we have. Someone much smarter than me said culture equals behaviour, and that every single behaviour that stacks up on top of each other equals a culture, and that holds to me to be very true. And there's a set of behaviours that we have that prevent people from wanting to share. And from my experience, most of it is that especially as clinical colleagues, we tend to pick holes in each other, and we tend to sort of shoot each other down sometimes over what could be perceived as sometimes they're really important things to mention, but other times it can be sort of slightly less important issues. But people, when you have that happen to you enough over the course of the years, even when you've done something that's really bloody good, you still have that nerve to stand up and say, I've done something that's really bloody good, because you don't want to. You're nervous that you're going to have people who are potentially criticize you for it. And I think the other point is that, and this is probably just generally an English thing, if you go to America, and you talk, Americans are generally quite good at saying, I've done this and it was great, or they're a bit more kind of like candid and honest and willing to promote stuff that they think is good. Whereas in England, we're not that way. It's like, oh, that was good, yes, clap, move on. There's a bit of culture there that's just generic stuff that I think is more difficult to overcome. I think that's a bit more embedded. But yeah, I agree with you. The adoption spread, it's something that we have to get better at, and we could spend a whole hour talking about how we could do that well. But really valid points. Thank you, Janet. Nav.
Well, John, I don't think I've got much more to add to the other than the wisdom, but just a couple of things. I perhaps just respond to Marc's really well articulated point about the national versus the regional, or the regional versus the local, or whatever phase of policy implementation we're on at the moment. And I think the intention is never bad, in terms of national programs or because if you take, for example, competition and choice, when that was launched in 2006 or whatever, I think the intentions there were good, weren't they? They were trying to kind of encourage things to happen around what patients' perspectives were, and to drive maximum sort of value. Now, of course, the implementation of these things has been a problem, and now we're in a position where we want providers to collaborate in a system which is not necessarily yet designed to enable that, because we still have financial control totals which are allocated to providers, and there's still a number of things which may get in the way of collaborative type of endeavours. So I guess what I'm trying to say is that, Marc, you're right. The national initiative should be a mechanism to encourage things to happen on the ground. I completely agree with that. Sometimes, as you say, the implementation and the way that these things are interpreted can cause us some difficulties around that. John, the only other thing I wanted to say, which is probably maybe just to emphasise, is that when we talk about the demand pressures that the NHS is under, and then we respond to supply-induced demand solutions like more gateways, more lanes, or more pathways, which is I think a natural response to a difficult problem that we're facing. Intellectually, though, sometimes that doesn't stack up. So if you think, for example, that people turn up to Maria's A&E department, over the weekend, maybe with certain things which people think, well, why are they there? It's actually because arguably there's some unmet need, and that unmet need has been not fulfilled for whatever reason, and no one's to blame. It's just the way these things are. So the answer isn't let's create more opportunities for people to go to for appointments, when actually we know that might not address the problem. What might address the problem is figuring out where the demographics are for some of these people, understand where they're living, how they're living, what the conditions are, what social systems are in place, what community oriented sort of things could be deployed to kind of support some of these things. So I guess what I'm trying to say, John, is we sometimes focus our innovation or transformational approaches on the wrong solutions, rather than thinking about tackling the problems at source, and really mobilizing our innovative thinking at that sort of level. Does that make sense? I hope I've tried to make that reasonably clear as a construct.
It makes fantastic sense, and completely agree with what you're saying. I think from my experience in working with some economists on this sort of stuff, some health economists on this sort of stuff, the view that they give is that, well, so this is taking the point you've made and just going off on a tiny tangent. The first point about what you've made is that we really need to understand the unmet need, and I don't think we spend enough time doing that. And I think for one of the things that is difficult, or I've not seen, and Mark and Janet and Nav, you may have, Maria may have seen this over with your experience, is that I don't see there being specific initiatives to look at unmet need of why people present when the pathways exist already. So access could be an issue, but then there can be other reasons why people do present, and I've not seen many initiatives that focus upon that specifically, although it is an issue that's discussed. So I think it'd be very interesting to look at just, you know, even a small sample of what those issues were and why people presented. One of the other arguments I hear to sort of open up doors to allow people to access care is that if you open up the door, that there will be a flood. What the health economists say is that if you look at health behaviour, if there has been insufficient supply to meet true demand, what you will see when you improve that access is initially a surge, and that surge will last sometimes from weeks, sometimes for months, but rarely longer. And then once people know and accept that the demand, the supply is there to meet their demand, then the demand starts to tail off. So the nerves and worries that we tend to see about opening up these extra routes, if the route truly meets the need of the patient, you will initially see a surge no matter what, but then it will calm down over time, is what I've been told. I don't think we've ever got to a point I'm not convinced that we've got to a point in this country globally where we have sufficient supply to meet the demand that is out there. And I would be interested to speak to colleagues in other systems in other countries where there may be sufficient demand to meet supply, but I couldn't agree. That was a really helpful point now, but I couldn't agree with you more. I'm just a little bit conscious of time, and obviously the time of the panelists is very precious. We only have that for another sort of 10 or so minutes, and I'm sure that there's colleagues who are listening in who would have some questions that they want to ask. But is there, Maria, Mark, Nav, Janet, is there any further points or comments that you wish to make? Maria.
I just wanted to add one more point, I think, that links in with what has been said, and to which I have no answer for what the solution is. But talking about transformation and being the way forward, working collaboratively, and about teams having the opportunity to actually access new programs such as CLEAR, but there are many others. We have been, and I think that, John, you agree, in many situations where the regions have been interested in bringing opportunities of transformation and its projects to different trusts across the country, and where the first reaction to in conversations that we had is why us, what are we doing wrong, and why do you want to do a project with us? And that's not surprising, but again, it comes back to culture and to blaming culture and how do we change that around. But once we start unpacking and talking about the opportunity and what we can do with that to improve, not to close services or not, it's quite interesting to see how people can shift the way of thinking. And again, I don't have an answer to how to change that culturally, especially at the system level. But I think it's something to keep in mind once we keep working towards transformation all across the NHS. That's all I had to say.
No, thank you, Maria. It's a really, really well put point, and changing that dynamic from national down to provider, I think, is a long-standing one. And I don't know, Nav, Mark, Janet, have you ever seen that change or evolve over the years, or is that pretty much held true?
There's always the intention to want to do that. I've not seen any policies or any reviews or anything that has not got an intention to do that. And I think it's how we operate and how we develop our relationships that's the most important thing. unfortunately, we rarely achieve it satisfactorily because of the pressures around our performance in the NHS. For good reason. Those, you know, our performance and constitutional standards reflect our promises to the public, and they should be seriously taken into consideration. But we often miss that great opportunity to really listen and understand what's happening on the ground, and then reflect it in policy. And I've experienced both of those, and it is really hard to do it. And I don't think we've quite cracked it. Hopefully we will do as time goes on. But I think we can't go wrong so much. The one thing I don't think we do well is include the voice of the citizen in things that we do, because that actually is very hard. It's very hard. There are lots of different ways to do it. It actually has a cost implication to it, because that's his valuable time we're asking for feedback in. And if we did that, I think, and stuck by the feedback we've got from the people who commission us, and that is the public ultimately, isn't it? I think we'd really improve. I think we'd really improve, and we'd be able to stand by what we do. That's a little bit blue sky sometimes. It shouldn't be, should it? But it feels a little bit blue sky.
No.
It's interesting.
Go on, Mark, were you going to say?
Well, I don't know, because I'll just go. I might start ranting. There's definitely something here about, Marie said, you know, changing the culture of an entity which is manageable, right? So the NHS as an entity, and talking about changing the culture of the NHS is almost, too big a thing to try and achieve from a nationally driven perspective. But I was just reflecting on the importance of senior leadership and managers providing air cover to those people, to those that they are responsible for, or that, you know, part of the role of a senior leader is to provide air cover and a safety net for those operating with them to be more transformative. So because we are inherently a public sector organisation with responsibilities to deliver services to the public, but also incredibly political, right? And therefore providing air cover is a valid solution to ensure that you've got a culture that you can hold on to locally and get things done. I'm not sure that's coherent, but
fair enough. Marc, Janet, Nav, Maria, thank you very, very much for the thoughts there. I found that be a really uplifting conversation, actually, discussing a range of different challenges. We have about 5 or 10 minutes left. I just want to open up to the floor, and just to see if anyone on the call who's been listening for the last 45-50 minutes or so had any questions for the panel. And if you do raise your hand, if you could just say what your name is and who the question is to, if there is a particular person, that would be great. So does anyone on the call have any questions in any way, shape or form? Oh, Caroline, yes, please go for it.
I had a question for Janet. You talked about turning the dial, I think, and shifting public perception. How do you think we can go about it? Because people are working so hard, but unfortunately, all of the recovery headlines, like we said, has some negative effect. I just wondered if you had any ideas on that.
I do. I've got lots of ideas in it, Caroline, because it's a bit of a passion, and I'm always trying to get the NHS engaged. The first thing to say before I say anything more is I apologise, but my dog is at the side of me here and snoring very, very loudly. So if you can hear that, it really isn't me. It's the dog. That's the first thing to say. Second to say, I think we need to have a programme of work around lived experience, listening to people, what people want to tell us, not what we ask them. So I think there's value in surveys and what have you, but we need to be listening to what people want to say as opposed to what the question that we want answering. And I think that is a massive work stream in the NHS that we could develop alongside the voluntary sector and invest in. So I think it'd save us tons of money if we did that. So we really understand. And then there's prems and proms. you know, patient reported outcomes, patient experience outcomes. I think we really need to flood our system with that and have modern and digital ways of collecting that information. I think we should be listening to what people do, and that is use social media and comment on social media. I think we should be listening and looking at that, maybe asking for feedback in that regime, not specific feedback about individuals, sort of individual experiences or individual conditions, but actually generally about how we feed in what are the processes that are failing for us. And then we can get more focused on that by asking for feedback as clinicians once at every consultation about how I've given you the care that mattered to you today, asking those sorts of questions, and then when those questions are asked, reflecting and taking action. And I think that builds, so it builds from personal one-to-one level to strategy level, where we can start to use social media and lived experience to form policy.
Thank you. That's all.
Thank you very much, Janet and Caroline. Claire.
Thank you, John. I was just going to say thanks for a really interesting conversation. I'm a nurse by background, working for Clear at the moment, and I really agree with nearly every point that you've said. And part of my challenge is transformation just good practice? Because I think it is, and I think it's that we're just not sharing through leadership and through organisational change, and how we spread and embed good practice and, you know, change is vital to all the work that we do. So it was just really that point I wanted to make.
Fantastic, thank you very much, Claire. So Claire, was there a question there, or was it just to sort of make a comment? It feels like that was just to make more of a comment.
No, it was just a comment really, and it's just the struggle isn't it? It's the leadership and the embedding good practice. That's the hard stuff, you know.
Yeah.
John, thanks. I just wondered if I could sneak in very quickly as we come to the end of this conversation. It was just that I'm again reflecting on Janet's point about engaging people in the design of things. I think, Janet, if that's not a terrible paraphrase of what you said, but I guess for me, John, a good place to start any transformational work is to identify the people who we're not engaging with, and the people who are not taking up the opportunities of health, or, you know, their follow-up appointments, or a particular service or whatever, because actually something's going on there, and we need to figure that out before we just design a one-size-fits-all solution that, you know, that kind of covers everything else. So I kind of, and those numbers could be quite small numbers, and they're often quite manageable numbers of people, and not that difficult to, you know, contact them and speak to them and have a chat with them, because sometimes the engagement point is so potentially so big, and, you know, where do you start? So I often wonder perhaps to start with people we're not reaching out to, or people who are not turning up, people we're not connecting with, and sort of see where that takes us in our design principles.
And I completely agree, Nav, and it's one of the hardest things to do, isn't it? Is to put the effort in up front to really engage with the people who need it most. It's a massive challenge. Eve.
Hi everyone, sorry I was a bit late to this session, so apologies if you've discussed it earlier, but I just wondered what your views are on how we work with the private sector going forwards in terms of the NHS. Marc will know this from our work in ophthalmology, seeing kind of cataract private sector taking over a bit, and also I'm getting a feeling that Specsavers are trying to develop their capability to manage things like glaucoma and AMD within those private services, and it seems to me that it's here to stay. And I just wonder if you have any views on how we can work in a transformative way with the private sector to ensure that the NHS continues and is sustainable, but also potentially to optimise that sector for our benefit.
Janet.
I think providing the independent sector, private sector, and social enterprise, and whoever wants to work with us, works to our tariff and doesn't have privilege. And, you know, I've not got a problem with it. I don't know whether that's politically right to say or not, but, you know, providing the level, the field is level, and we are prioritising NHS services. But if we need extra capacity and we are paying the same tariff and we're not elevating that, why would we not do that? Provided we've got the quality and the quality standards. And I was around long enough to know, remember the choice network that we created quite a number of years ago of providers who could work with us on the similar tariff of the same quality standards. And I was implementing that in the Northwest, and it was quite challenging to do, but you know, why not? Why not, if we've got good quality services and we're not giving those organisations privilege, why would we not use them?
Nav or Mark, do you have anything? That's a good question.
Well, yeah, great question, Eva. And I just jump in there. So a couple of things. I mean, see, sometimes we think about private providers as kind of reducing elective waiting lists and all that stuff. And I sometimes worry about, you know, we're talking about core NHS staff still providing the work, so we have to be a little bit wary of that. In the context of what you said, though, Eve, I mean, this goes back to this sort of greater use of technology point for me. In that actually, if we design a model of care, we design a model of care based on all the principles we know. We should be kind of folding into that all the technological opportunities that sit within that, so we're not having to go through some manual process or some paper-based process. And if Specsavers can, for example, diagnose a retinal problem on the back of something, and they should be able to access immediately the ophthalmology department for whatever it is, rather than having to go via some tortuous route via the GP to set some referral off somewhere. And do you know what? So I think we can be sharper in our design around these things, and actually that cuts out all the kind of waste and fragmentation and delays in the system. Ditto hearing things, ditto other things that kind of community pharmacies can now do. So I think we need to incorporate the broader community of providers out there. But as Janet said, be clear about the specification, be clear about the brief, and be clear about where that sits in a pathway of delivery, so it's not just another thing that happens alongside, if that makes sense.
Mm.
Thank you. Can I ask one more question to Janet and Nav? What do you think the future of GP partnership is?
I'm going to get Janet to answer that one.
Well, I hope it's got a hugely fabulous future, because it's the underpin of our NHS, isn't it? And we should be very proud of how our GPs work together in partnership. So I hope it's got a huge future. We've got PCNs, of course, at the moment too, and I hope they've got a future too, because they're shaping up, aren't they? And there's some great work. We have, in my everyday life, there's some fabulous work that goes on in primary care networks. So I would always promote that. We see 92%, don't we, of the contacts in the NHS are in primary care, and that makes me feel really proud. So and they're able to shape and respond to local need, sitting in neighbourhoods and doing. Am I saying the right thing here now? I'm very proud of.
I think it's too politically charged a question, Eve. That was a bit naughty of you, I think, to throw that in at the end.
But that's my personal view, but I'm not, I'm not going to be that decision maker. But I hope to see.
I mean, I think there's a contextual point here, Eve, because I think the partnership model has stood very well over many years, and not because of any failing of the partnership model, but I think, as we know, lots of GPs don't particularly want to be GP partners and want to operate in a salaried service, which is perfectly understandable, and no one would blame that. So I think context is changing, life is changing, models are changing, and we have to adapt to that. Having said that, as Janet said, the partnership model creates opportunities, it creates efficiencies, it creates innovation and so on. So we don't want to lose some of the things that have made general practice great. So I guess it's a politically charged question, I think.
It is a bit, isn't it?
Mindful, though. Yeah.
But not forgetting that some of our GP colleagues prefer to have a salaried role, don't they?
Of course,
they're comfortable with that. So okay. It's a mixed model, surely.
Yeah.
It wasn't meant to be politically charged. I just doing projects as part of the Clear team with GP partnership model. It seems to kind of be at odds with the in terms of the principles with the PCN approach. There's the PCN is about collaboration, sharing, and the partnership is very much private sector type, and so there's a bit of a clash of kind of principles that sometimes make it difficult to get collaboration.
I think we could probably talk offline because there are kind of issues. I mean, GP partnerships, or are they not? Most of the fund, they're NHS contracted providers, so it's not private in that sense, or it might operate in an independent contractor mindset. So we have to be kind of clear about the terminology. And of course, all GP practices are members of a PCN, so there is a, so there is a requirement there, and it's a maturity point, Eve. The PCNs came into place in 2019, and it takes a little while for things to sort of bed down, before the next reform hits. So it might just be a timing issue in the areas in which you're working at the moment.
Brilliant. Well, on that exciting note to end the conversation with an interesting question, I just want to say a huge thank you to Janet, Nav, and Marc and Maria for attending today, and obviously a huge thank you to everyone who's joined. We'll come to a close for the session, and I guess I don't have a huge amount more to say, other than it's been really very, very interesting. I always learn a lot when I talk to Nav, Janet, Marc, and Maria. It's always just always very, very, very pleasant, inspiring, and productive conversations, and today has been absolutely no different. So a huge thank you again.